Okay, so we're going to move to abdominal assessment next. And of course, again, as I said before, with abdominal assessment, for this one, you need to be in sports bra or shirt so we can see the landmarks, which we'll be talking about right behind my shoulder here on the board, the belly. Again, you always start with your introduction. This one's 2 points. Hi, introduce yourself, reason for visit, do your hand hygiene, provide privacy, and make sure that you end your assessment. So before I do abdominal area, I always like to start with asking you and reviewing what's in these different quadrants. We talk about the abdomen in terms of quadrants, right? This is my belly button, nipples, and the belly button is the landmark midline, and the belly button then is the sort of landmark that we use to identify the quadrants on the abdomen, which is why you need to be able to see them because people's belly buttons are in different places. The other thing I need to tell you, because I will ding you on this one right away, is that you need to be on the right side of the patient for abdominal assessment. You need to be on the right side of the patient for abdominal assessment. And I'll tell you why in a minute as I go through this. At all times for abdominal assessment. I always need to assess my patient from the right side. Right, left. I'm always over here on the right side of my patient when I do abdominal assessment. This is actually a good visual for me to show you on here as well. So when we do our quadrants, we say right lower quadrant, right upper quadrant, left upper quadrant, and left lower quadrant. Remember that from your ADNs? So what's in these quadrants becomes the question we need to review before we go do anything to the abdomen area. Right lower quadrant, what lives here in this area? What's the main organs? Appendix, cecum, what else? What else is here?
Like the lower part, like
that's probably down more in the pelvic region, not the abdominal. Boy, you got eggs down there. You're way up there. I'm talking up in the belly, right lower, not down pelvis, not pelvis. They may be down in that area, but for the most part, that's down more pelvic. I think down there in that area. But and what lives in this area? Appendix, cecum, and what colon? The ascending colon, going up. Okay, great. What lives in the right upper quadrant? Liver, gallbladder, duodenum, duodenum, potato. Left upper quadrant, what lives over here? Spleen, stomach, pancreas, transverse colon comes across that way. Things get displaced because the heart, the tummy kind of comes at an angle, you know how that stomach shape, right? It's not just a straight thing down the esophagus, how that tummy sort of angles off that way, remember? And then left lower quadrant lives what? Sigmoid colon, descending colon. What lodges and gets stuck here? Poop. This is the end of the line. So if I'm palpating here and I feel hard, nasty stuff, solid first, my first question before I go in, my God, you have a tumor. What might I ask first? When was your last bowel movement? I haven't pooped in a week. There's a problem. Yeah. Then I might want to do a little digital exam and maybe do some lubrication or get some suppository in there and give them some from the top to work it out, right? Right? Something, lactulose, something, right? Work it out one way or another. Back in the day, your old instructor was good for his manual disimpaction skills. They always call me as a nurse aide. I had the long fingers. I get in there and get them. Manual disimpaction. Boy, I used to hate that. I had a nurse that used to always call me for that, church nurse. God bless her, right? She's so mean to me. Come, I need your manual disimpaction, body. I won't tell you what I really thought. Okay, we're on film. But anyway, okay, so that's a review of the quadrants. So we have the lay of the land. Okay, so now let's talk about the areas of the belly. So for the belly, when we're looking at the skin of the belly, color, cleanliness, moisture, temp, color, right? Texture, vascularity, and lesions. We're looking here for stuff related to skin. It's a little different here. What might be problems with stuff we see in the skin with vascularity? Those would be colors, but what about other issues with skin? Stretch marks, striae. Very common, wouldn't be surprised. Maybe areas of ecchymosis. If there's some vascularity issues, something's not perfusing to the skin well in the abdomen area. We're looking for that kind of discoloration. Posture and position of the abdomen. And this is always done. I should have put that up at the top somewhere. Oh, I did. Right side of patient. I put it up top. The other thing I forgot to say is supine. Patient is always laying flat. So like my mannequin right there I have, which I'll move to in a bit. Have to be laying flat. So when you're laying flat and you're looking at the posture and the position of the abdomen, it should be a nice neutral looking abdomen. So we're looking at, I'll look at two together, posture and contour. Should be neutral looking. It should be flat maybe. Guarding is when I am looking at it and it looks tense. You'll see some tension looking at it. It doesn't look relaxed. You can tell when you're having someone look at the abdomen and they're already guarding or they're posturing. There's some kind of posturing to the abdomen. Or are they totally flexing their abdomen to try to show it off? Like, no, I don't need to see you flex it, brother. Relax it. All right. And I'm trying, it's not a flex contest. All right. I got to show you, I got some abs. I need six pack right now. That's what we're looking for. Breathe, relax, just relax it. Right. So what are they doing when I look at it? It should be flat. It shouldn't be rounded or distended. What's distension mean typically? Ascites, fluid. We don't want to see that. Okay, or it could be obesity, it could be pregnancy, or what else? Gas. All right. And again, we'll find out more by percussing it, which we'll get to find out the differentiation between fluid and gas. It says scaphoid, which is more concave. It goes down. Love those people with flat abdomens. Them days have passed for me. And then I'm going to look at that umbilicus or umbilicus, whatever you like. And I'm going to look around that area in particular to see if I see any kind of herniations, any outpouching, any masses. Is it pulsating? That shouldn't be happening. Are there any other kind of irregular movements that would lead me to believe that there's something wrong with the area around the umbilicus? Does it make any difference if it's a innie or an outie, as somebody says on the belly button? It's not a big issue. Probably just how it was cut when they were born, unless it's a herniation or an outpouching. And then next, we auscultate. Percuss, palpate last. This one is critical, you palpate last. I will fail you if you stick your hands in here first. Why? You start stirring up noises and bowel sounds and stuff before we even get there. if you stick your hands in first. And you shouldn't be creating that first. You want to see what the patient has naturally. Because once you start manipulating the abdomen, you're going to create activity. Once I start massaging and palpating and digging around, then I'm creating stuff that may not be present. So know that. So you will be toast if you go sticking hands in there. Hopefully I impressed that into you the first time. I train you with that off the top, right? Don't be putting your hands on nothing. Don't be putting your hands on nothing in Dr. Nation's class. He be wanting you to look first, right? Use that assessment skill of your eyes. What do you see? And this one, then we go to stethoscope. It says bowel sounds in all 4 quadrants. They can be what? Hypoactive, active, or absent. Obviously, we want to hear some bowel sounds, right? In all 4 quadrants, your book will say for 5 minutes. In each quadrant, I use the diaphragm side. In each quadrant of the abdomen, I'm listening. The other thing to tell you about the quadrants, see what I'm doing? Mm-hmm. I'm going in a pattern. I'm always starting on the right side of the patient. I will reinforce that. I start from the right lower because I know where I am here. I know what I'm going on down here. And I work my way around in this motion, right? It says that's counterclockwise. I don't zigzag. I don't mix them up. I go this way around because that's the way the bowels are moving. Right? So it makes sense. I go here, 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 here. So I can hear what's happening in each area.
How long do you want us to listen to each one?
A few seconds, because you're in a 10-minute sign off. So you ain't got long. A few seconds. I'm looking for technique, and obviously, because most of you are all healthy people, you should have bowel sounds, particularly if you ate or didn't eat, right, that morning before you came here. May have hyperactive because you'd be nervous that morning, perhaps some of you. Most of you seem to be a little unglued with little old me. I don't know why. I'm so friendly. Landmarks, and these should be on page 493. Vascular sounds, tell me if they're not. I may have to update my pages.
Not on the new book.
Not on the new book, probably old book, 493.
We got 499 and 498 for the book.
498, 99. Okay, 490. Oh, my pen's not ready. 98. 99 on the new book, I'm being told. And here are your landmarks. So for abdominal aorta, and these are to diagnose hypertension. You're going to hear a bruit sound in these, and we don't want bruit. That's bruit hypertension. I told you that for carotids, right? Abdominal aorta is midline, right above the quadrants. So these are my quadrants. It's going to be abdominal aorta. It's going to be right above the quadrants, right at the above, right here in the middle. I'll hear it. Right above the quadrants, right in the middle at the midline. So I was kind of epigastric, below the gastric, above the quadrants. So when we look at your abdomen and you see your quadrants, you can lay of the land with when you guys look at each other's bellies. You want to go right above the quadrants. Renal arteries are right next to your aorta. So they're off a little bit. You think you have one on the right and one on the left. And the iliac artery sits slightly below the umbilicus, again on the right and the left. You'll see pictures of those in your book. They should have took femoral arteries off, right? Or are you seeing it on yours? Okay, they took that off. We don't do femorals. And then we go to percussion. And this is again where you're going to differentiate between your masses versus your gas. We're gonna do, when you all know percussion because we talked about percussion before, and some of you got percussion on this first go round. And I did the test where we do is a dull, which could be sign of a tumor or problems with a large liver or spleen. Or is it the gassy tympanic sound, which you would expect to hear kind of over your abdomen if you percuss? I just ate lunch, so it's kind of hollow versus the dull sound of my leg or something, right? What am I hearing when I go into percuss the 4 quadrants, right? Sounds a little different, but similar. All 4 quadrants. I do my same pattern, all 4 quadrants. And right? And then something called liver span or MCL. And I have page 497 and they need to update that for you all as well. Let me get a better pen. I have 497 in my old book. You can tell me where it is in the new book. You see it? Liver span. And what you're doing here is I need to know what the span is of the liver. We know it's in the right upper quadrant, but you have a big liver or you have a liver that's normal size. And I need to know because I'll be able to percuss it and tell by sound of it where it starts and where it ends in this region. So let me tell you the lesson first. Right mid-clavicular line is where we're going. And you start below the umbilicus and work your way actually rewind. Start at the nipple line and work your way down to the umbilicus, maybe even below the umbilicus.
Right.
Let's do it that way. I think I'm reading my notes backwards. And you should hear from a tympanic or a dull sound. I'm looking for the body of the liver. It should measure 6 to 12 centimeters. So what does that look like? So I go right mid-clavicular line. Right mid-clavicular is nipple line, right, typically. And I'm gonna start up here percussing, so I'll hear a different sound. The lungs. Come down, come down, come down. Oh, it changed right there. That's my first spot to mark. Boom. Then I keep percussing. Down. That sounds the same. Sounds the same. That sounds the same. Oh, it changes right there. There's my second mark here. This is the span of the liver. That's what we're doing for that test. That makes sense? So this, you're fine-tuning your auscultation skill. You will hear a difference between the tympani of the lungs versus that dullness of a liver. You know what liver looks like when you see liver. And it will feel different too under your fine-tuned percussive hand. You will now be able to feel and hear that difference in sound to be able to measure where we are. And this should be somewhere around 6 to 12 centimeters. That's the span. And then I have, and I put here warm hands. Some people do this to warm your hands before you go digging in somebody's belly. Warm them up, or some people use hot water if they know they have really cold hands. I'm going to do light palpation and then deep palpation. And then I'm going to find my rebound tenderness or McBurney's point. So again, light palpation. Feel around my right quadrant to see if I feel anything. Go upper, feel around, see if I feel anything. Let's go over to the left. I feel. I'm looking for those things we talked about.
Is this a marking or is it
Yeah.
more of like a massage?
It's more of a massage. Light. This is light. Looking, I'm always light watching the patient's face when I'm palpating. That's the other point I should put here. I always say that because I get real dingy if you don't watch patient's face. Because why am I watching the patient's face when I like palpate? Yeah, am I hitting anything on that light go round before I start digging deep? Because I'm gonna get in there good in a minute. They don't know it, but like relax, just breathe normally. And I'm just feeling lightly on the first go round. And just looking, watching their face, because they may grimace, they're tender, start flexing, just real light, a light massage, just a light. Deep massage is with breath. Now I come back to my base on the right lower quadrant, because I'm always on the right side of the patient. I have them take a breath in and blow out. All the way out, exhale. As they exhale, I go in there deep. I really want to feel around now. Deep. Let them take a breath again. Exhale. And deep into that abdomen on the left side. Same thing on the other two quadrants as well with breath. Okay. McBurney's point, the final test, is from the right side of the patient. I'm standing up. I grab the belly with two hands typically. I pull all of their gut toward me and let it go. Rebound. If they're a hot appy, they will jump off the table. Acute appendicitis, they'll jump off the table. They hate that test. I'm pulling all the gut toward the right side where that appendix is swollen, and then I pop it free. And boy, if it's a hot one, they'll jump. Positive sign, positive McBurney's. We don't want that. They'll talk about it in your book being from the umbilicus down to the right iliac. It talks about right in your book. That's the theoretical point. I don't care about that. I want to make sure you can get the exam right, the physical part of that. Okay. Any questions? Always once, yes. It's really a test for appendicitis. All the question was always on the left side. It's the only side I'm concerned about. It's really an appendicitis test. Yeah.
Are you gonna ask us in the competency like the organs and the upper, left, right, quadrant?
No, only if you get a positive finding with your patient. Then we'll need to know that. I'll go, oh, kind of like we did with today. We had a neural finding on one of our patients, right? And I had to probe that with you. I'm like, oh, we had a positive finding. Let's do a little pause, because most of you expect to be normal. We're all normal, fairly healthy, except me. I'll give you some stuff today, musculoskeletal. If we get a positive finding, let's talk about it. What does that mean? What does that feel like? Right? What should be there? If you hit one of your peers today, and you're palpating in here, and they go, ow, you probably need to send them out of here pretty quickly. I need to redirect them right now. That means something's going on, right? So positive finding, we will stop and probe, and you will need to know. I'll go, what do you think's going on there? Or if you hit them up here and something's alley, I'd be like, well, what do you think's going on there? So you should understand as a baccalaureate nurse what's going on there. If you hit them down here and it's like, ow, they're like, dang, okay, what's that hurt? And that's really kind of your poop chute. What's going on down there? Did you evacuate, right? Have you cleared out? Is there a clean, right? First thing, I'm like, it shouldn't be hurting there. Ain't nothing in there but descending colon primarily on this quadrant. If you're doing an owie here, I'm pushing on something, right? I know what's in there, what lives here. And I'd be like, oh, that could be really bad constipation. right? Where's the pain at? I mean, this is where my brain goes. Where's my brain go? If I hit pain up here, what am I like? That's liver issues. I might want to be seeing some liver enzymes. My brain starts going into places. You're telling me you have some liver tenderness when I'm palpating. Then my brain needs to know what lives there. And as a nurse, then you start thinking nurses, as you're dealing with Tina or whoever, or a patient. If I hit tenderness in that area, where am I going to be going next? What do I expect for orders? What do I expect I want to follow through? What do I expect I should be doing for my patient, right? Probably need to get some labs, probably need to be NPO. Let's see some scans, maybe a CT,
Even description of
ultrasound.
Even like the description of the pain, like is it going, is it breathing?
Yeah, well, I could do a Codera or an old chart. That's where I go back to that. That's my anchor. Remember, I talked about those early on. If you get a positive finding, that's a great place to go back to get more information from your patient. And you go back into, I go back to old chart or I go to Codera. You can use either or. It will get me in the same, relatively the same place. A positive finding, that's your focused exam, folks. I just gave you a tip, you on video too. For focused exam, because you're doing 2 focused exams, you're about to do a call. So you're questioning for focused exam for a positive finding, right? Becomes old chart or Codera, right? Describe when did it start? Tell me about it. Onset, location, duration, right? Character, onset, Codera, location, duration. I mean, they're similar. You can go either place. I don't pick a favorite. They'll get me the information I need. The fact of the matter is I won't go past it and go, okay, that was a positive finding. We identify it and call it out. And then in the case we need to probably start probing it. And then when you're making your recommendations and your assessment on your SOAP, then you would make your assessment and your plan would be, I expect that XYZ will happen. This is what I'm kind of anticipating would be going on with my patient, right? You're welcome. Bye-bye. Any other questions? Okay, so let's.
Can we go over the quadrants? Let me know the organs or anything that's in all the areas, please.
Yeah, we'll go over the quadrants. Yes, I'm gonna start recording.